Good evening. Thanks very much for coming along to hear us talk this evening. My name is Rochelle Flanagan, and I was diagnosed with young onset Parkinson's just over 7 years ago. I actually picked it up when I was working in my clinic as a dietitian. I was actually 3 months pregnant at the time, and I noticed that my handwriting was very small. A patient came to see me after a 5-year gap. And when I looked at my handwriting in the record card 5 years before, my handwriting was much bigger than it was that day. And I thought, that's a bit strange. And when I tried to make my handwriting bigger, I couldn't. So I subsequently learned that it was micrographia, which is small handwriting, which is associated with Parkinson's. So I had to wait until my daughter was born and I'd finished breastfeeding her before I could have a DAT scan to confirm, because the neurologist thought I was very young and it was unlikely that I had Parkinson's, as my only symptom was the micrographia. I did have a kind of aching shoulder, a symptom that I was going to a physio for. So I had a test for a trapped nerve and I had a brain scan to check that I didn't have a tumour, which many people with young onset in Ireland anyway are put through. But the DAT scan showed that actually I did have Parkinson's. So I suppose what I was kind of wondering was, are there other people like me out there that have Parkinson's? And the reality is, in terms of the prevalence of Parkinson's in women, we basically make up 40% of people living with Parkinson's worldwide. But the image is not portrayed of that. It tends to be that of an older man. And the reality is that actually up to 30% of people with Parkinson's are under the age of 60, which obviously has a big impact for people when they're, have families and, mortgages and jobs, etc. So this was something that, I really wanted to kind of research into, but also in terms of diet. I went to the World Parkinson's Congress in Kyoto to sort of see if there was any information about diet for Parkinson's, but there wasn't very much. But I have to say, over the years now of doing research, I don't think there's any condition that I've actually worked with that is in need of more personalised nutrition than Parkinson's disease, regardless of the age or stage of the condition. So today I'm going to focus on living well with Parkinson's through personalised nutrition. So I'm just going to start off by what is personalised nutrition. This definition actually comes from a nutrition research colleague of mine, Professor Eileen Gibney. And basically it is providing dietary and lifestyle advice that supports the individual to change or maintain a balanced dietary intake that meets your personal requirements. So what we do as dietitians is we look at your current food intake and we look at what your sort of body's needs are. And then we look at the social factors in terms of how easy is it going to be able to change your diet. And we need to consider the individual variation between us all, because we talk about Parkinson's, we say you meet one person with Parkinson's, you meet one person with Parkinson's. So the treatment has to be delivered taking into account your individual needs. So that could be your individual diet needs. We all have different microbiomes. We all have different genes. We are obviously different ages. We have a different weight, our body mass index. We do different levels of physical activity. We sleep differently. And obviously there is the sex differences and also gender differences. So PD nutrition related issues are very personal. So this picture here is actually from another number of colleagues of mine who do research in nutrition. And it shows you many different impacts of Parkinson's symptoms on nutrition. So things like dysphagia, gastrointestinal dysfunctions, so constipation, things like cognitive issues, mood, apathy, tremor, dyskinesia. These are all impacted in nutrition. So I'm just going to focus, because we've got a short period of time, I'm going to focus a little bit more on the women, because often it's, focus on the men. So I'm just going to highlight here in terms of some of the differences in women with Parkinson's versus men in terms of the impact of Parkinson's on our nutrition. So one of the things is that in terms of gastric emptying, so your stomach emptying with food, that is actually slowed down in people with Parkinson's. And women have 3 to 4 times, it's more prevalent, 3 to 4 times more prevalent in women than it is men. So that's slowing of food moving out of your stomach. I'm going to explain later on why this is important. The other thing is that your intestines, the motility, the movement of your intestines, slows across the menstrual cycle for women, and also can be affected by the menopause transition. And also constipation is more prevalent in women post-menopausally than premenopausally. In addition, osteoporosis is more prevalent in women than men with Parkinson's, and generally, even women without Parkinson's have a higher prevalence of osteoporosis. And also in terms of mood issues are more prevalent in women, so women tend to suffer more from anxiety and depression than men. And also urinary issues, again, are more prevalent in women postmenopausally than premenopausally. So these are all kind of differences that need to be taken into account when you're kind of tailoring a treatment for someone with Parkinson's. The other thing is dyskinesia is more prevalent in women as well. So, and the other thing that impacts women is that we suffer from more wearing off, and our fluctuations, we have fluctuations in our symptoms more often. So that basically is when most people are on a thing called levodopa, which is the main medication for Parkinson's. And what happens is after a number of years, your body kind of the medication doesn't sort of work consistently. So it's a bit like when you have diabetes and their insulin sort of wears off and they have to take another dose of their medication, their insulin, to bring their blood sugars back up. So with Parkinson's, it's a bit the same. When your levodopa wears off, so that's when your symptoms start to come back and get worse until you take your next levodopa tablet, and then you go on again, so your symptoms are better. So people get these on-off symptom fluctuations. And the reality is with women is that we are more likely to suffer from these wearing off symptoms, and we tend to have more off time than men do. And this is partly due, they think, to this slow gastric emptying. Because when you take the levodopa tablet, it has to be swallowed down your throat, into your gullet, into your stomach. It has to go from your stomach into your intestines, and then it has to go from your intestines into your blood system and travel all the way to your brain and cross your blood-brain barrier. That's quite a long journey for a little tablet. So if you have slow gastric emptying, which I've mentioned women have 4 times more prevalence than men, it means that that tablet can sit in your stomach. And when you're thinking, why aren't I turning on? It's probably because it's stuck in your stomach. And when it gets stuck in your stomach, it gets broken down by the acids in your stomach. And also, some people can suffer from a thing called Helicobacter pylori, which is the bacteria in the stomach, can actually eat your levodopa as well. So it means that you don't get as much getting to your brain, and so your symptoms don't work as effectively, or your medication doesn't control your symptoms as effectively. And also estrogen and progesterone, our hormones, impact the gastric emptying as well. So these are things that are not really taken into account, I believe, as much as they should be in terms of dealing with the individual needs of people with Parkinson's. Oh, sorry, I did something wrong there. So the other thing is, I mentioned about women having more dyskinesia. So it appears dyskinesia is higher in people who are young onset Parkinson's, both men and women. But actually women of any age have higher dyskinesia than men, have more dyskinesia than men. And this again is due to levodopa. So it's basically a side effect of too much levodopa in the body. So I don't know if you're familiar with dyskinesia, is when people sort of rock and roll, it's kind of having too much levodopa in their system. And as I mentioned, young onset people with Parkinson's suffer from it, and also women tend to get it after sort of 5 years. And basically, one of the reasons is that women tend to have a lower body mass index. Your body mass index is basically where your height in meters squared is divided into your weight in kilograms. And the lower your BMI is, often that means that you absorb more of your levodopa. So women absorb more levodopa, so they tend to have more of the side effect of dyskinesia. And what happens is when you've got dyskinesia, is you can imagine if you're rocking and rolling, you actually are burning a lot of energy. So you lose more weight. And what happens when you lose more weight? You absorb more levodopa. And the levodopa makes you dyskinetic more, and it goes around in this sort of loop. And ultimately, you'll see here in the pictures that, sorry now, press the wrong button. Sorry now. So you'll see here on the right-hand side, that people who are weight losers have much more dyskinesia than those who are a stable weight. So women, we know, also, research has shown, may need a 25% reduction in levodopa dosage in comparison to a man, and that this might actually help to reduce the dyskinesias. So it makes sense, you know, me as a 58 kg, 5'6" woman, you know, shouldn't have the same levodopa dosage as a man who's 6 foot and, you know, 100 kilos. But this is not actually done on a regular basis in terms of titrating the doses based on our individual needs. So the other thing is that responses to drugs may be affected by fluctuations in hormones across the menstrual cycle. So in the My Moves Matter app, we've women who've reported in surveys that their Parkinson's symptoms are worse the week before their menstrual bleed and the week during their menstrual bleed, and that their drugs are not as efficacious. So these are all different things that we need to take into account. Other things in terms of that are important for people with Parkinson's to be aware of is vitamin B12 and homocysteine. So long-term levodopa usage basically is associated with lower vitamin B12 levels and increased risk of peripheral neuropathy. So you'll see here on the left-hand side of this slide, the symptoms of peripheral neuropathy are unusual sensations in the body, sort of like a crawling feeling under the skin, pain from light touch, pins and needles in the hands and the feet, muscle weakness, also twitching, muscle cramping. So a lot of the symptoms are very like Parkinson's symptoms, aren't they? So it's hard to sometimes define between the two what is actually going on. And we know that vitamin B12 deficiency leads to high levels of a thing called homocysteine, which is a neurotoxic substance that exacerbates Parkinson's symptoms. And vitamin B12 deficiency is associated with more rapid progression and balance issues. And cognitive decline and hallucinations are linked to this elevated homocysteine. So we need more research in this to basically provide individual recommendations for people with Parkinson's, which has not really been done at the moment. So if you're suffering from any of these symptoms, I would encourage you to talk to your neurologist about it. The other thing then is in terms of bone health. I'm focusing in on the women again, because women tend to have, you know, the higher levels of osteoporosis. And vitamin D deficiency is associated with osteoporosis and correlated with a higher risk of falls and fractures. And with Parkinson's, you do not want to end up with a fracture in a hospital, because being in hospital is not always the best thing for people with Parkinson's. There's a higher prevalence of osteoporosis in Parkinson's patients associated with a higher homocysteine level due to the levodopa. So it's shown that the longer and the higher doses that you're on in levodopa increases your homocysteine levels, which affect your bone density. So basically, and especially in women, maintaining bone quality might actually help to slow the progression of their disease. So again, this is something that's very important. And actually, there was a study quite recently called the Parkinson study, which basically was a dietary intervention where people took a supplement of vitamin B12, folic acid, and vitamin D, and it remarkably increased their quality of life and decreased their homocysteine levels. So these are the kind of studies that we need to see, a bit like the exercise studies. We need more research on personalized nutrition treatments for people with Parkinson's. I just put this one in terms of just showing the difference, the impact of sort of menopause in terms of women. So this is women, the impact of menopause on women who don't have Parkinson's, okay? So it's shown here that women over 60 years tend to be less physically active. Women exhibited significant decrease in physical activity the 2 years prior to their menopause, before the menopause, and that remained reduced. Also, physical inactivity was associated with decrease in circulating estrogen levels during the menopausal transition. And the menopause-related deficiency in estrogen decreases voluntary physical activity along with decreasing in dopamine activity. So our hormones have a big impact on us women living with Parkinson's. If this is what's happening to women without Parkinson's. And you'll see here on the right-hand side, in the image on the right, showing the impact of estrogen reduction and menopause. So basically, it shows, if I look at the bottom sort of level here, I can't remember which one is the pointer, but menopause-associated physical changes, increased blood pressure, increased fasting glucose, increased cholesterol levels, decreased, reduced pulmonary functions, decreased bone density, declined muscle mass, and grip strength. So there are the impacts on a woman without Parkinson's who goes through the menopause. So then you put the Parkinson's on top of that, it's going to give you a double whammy. So this needs to be taken into account in terms of women with Parkinson's with regard to, for example, from a nutrition point of view, helping to improve your blood pressure, helping to improve your cholesterol levels, helping to improve your bone density through good nutrition, but also needs to be looked at from a medication perspective with your clinicians as well. So, does personalized nutrition therapy work? So, does nutritional status affect Parkinson's disease features and quality of life? So this study here was done in people with Parkinson's who were between 60 and 68 years old. 8% of them had abnormal nutrition status. 25% were malnourished and 42% were at risk of malnourishment. And poor nutritional status affected depression and anxiety. They followed a 6-week nutrition intervention with a dietitian and nutrition nurse. They had oral nutritional supplement drinks for those who were malnourished. They got extra fiber if they were low in fiber, because a lot of people with Parkinson's don't take enough fiber in their diet. And they were also optimized in terms of vitamin B12, vitamin D, and folic acid if they needed it. And they were put on a diet called the protein redistribution diet. Men, actually, interestingly, had a higher prevalence in this particular pilot of abnormal nutritional status. And those who had worse malnutrition had more severe symptoms in all subgroups of the UPTRS scale, including the mental, motor, activities of daily living, and complications. So what happened with the pilot study? There was a significant improvement. This was in 6 weeks. A significant improvement in their malnutrition score, a significant improvement in their disease severity, their quality of life, and their nutritional status. There was a significant improvement in their self-perception of nutritional and health status, and this was associated with a decrease in depression and anxiety. So the concluding remark of this author of this paper was that nutritional status assessment should be a standard approach in people with Parkinson's. Although we need further research needed on the role of nutrition in progression of Parkinson's and other neurodegenerative conditions, disregarding nutritional features in Parkinson's theoretically worsens the disease process and quality of life. So the other thing I'm just going to mention, I mentioned about the fluctuations. So in terms of protein foods, many of you might have heard that sometimes when you take your levodopa with a meal that contains protein, that can impact how well your medication works. And that is because when you eat protein foods, so chicken, beef, turkey, eggs, milk, etc., it basically breaks down into amino acids. And when they cross the blood-brain barrier, they cross the same place that your levodopa crosses. So it competes. So we advise people to basically take their levodopa medication 30 to 60 minutes before their meals or 1 to 2 hours after their meals. Now, the issue with that is when you're taking levodopa, which often as we progress through the condition, you can be taking it maybe 5 or 6 times a day, it becomes really hard to time, and half an hour before and an hour after. And what happens is people inadvertently start to reduce their protein intake because they're so worried about the interaction with their medication that they actually leave out protein. And that's not a good thing to do for Parkinson's, because you need your muscles, we mentioned earlier on, and we need the calories from the protein, and also protein gives you vitamin B12, iron, and many other good nutrition factors. And also in terms of, I'm just looking here, sorry, what I was saying here. Also in terms of the adjustment of your protein. Sometimes when people I was going to talk about a protein redistribution diet. I'm going to go on to the next slide here because I just lost my thought there for a minute. So basically when this happens, when people have this multiple fluctuations, and what we advise is, rather than trying to time your medication, before and after every meal, because it becomes very difficult, we advise people to take a protein redistribution diet. So this means that you take most of your protein in the evening time. And that means that you don't have that interaction between your meals and your levodopa during the day, so you don't have to worry about it. So in terms of the guidelines are that we need to keep people to about 1 gram per kilogram body weight of protein per day, and no more than about 10 grams of protein during the day, and then the rest in the evening time. So the rest of the protein, as I say, taken in the evening time. So you'll see here in terms of the screen here, these studies were done quite a long time ago, but they had a very powerful impact on people's Parkinson's symptoms. So it showed that the PD disability score before the redistribution diet was much worse than after. So on the right-hand side here, bradykinesia score dropped from 41 down to 30. The likes of gait went down from 39 to 25. Rigidity dropped from 44 to 26. And on this picture over here on the left, it showed that people actually had 76 episodes of on time versus 17 when they weren't on the protein redistribution diet. And a more recent study showed that people with Parkinson's who were treated with levodopa, the disease progression was inversely correlated with adherence to the protein redistribution diet. So basically their progression slowed when they were on the protein redistribution diet. So quite powerful, but we need more research in it. The other thing is that when you do that, when you move your protein to the end of the day, one of the biggest side effects is dyskinesia. Because I mentioned that basically when you take your levodopa separate to your meals, it basically means that you absorb more of your levodopa. But if you're someone who has dyskinesia, obviously you keep it separate to your meals, you're going to absorb more. So if you have a protein redistribution diet, you're going to have more dyskinesia. So what has to happen alongside that is you need to consult with your neurologist, with the dietitian, to adjust your levodopa dosage downwards when you're doing a protein redistribution diet. And that can help to control. There is also some evidence that's showing that a higher carbohydrate to protein percentage in the diet can help to reduce this dyskinesia. And also to avoid weight loss, because sometimes people, they're trying to do this on their own because they can't get access to a dietitian. They don't take enough protein in, so they lose weight. But you can be put on nutritional supplements to help avoid that. And there are ones that are protein-free, so that are just contain fat and contain carbohydrate. But there's also potential to use protein-based supplementation, because recent pilot studies have shown that in an exercise rehab program where patients were put on the protein redistribution diet, if they took 10 grams of whey protein supplement twice a day, that it did not interfere with their levodopa absorption. Another study, again, a multidisciplinary intervention, rehab intervention, which obviously has been shown by our previous speakers, can help to improve Parkinson's. It was shown that the problem when you're doing exercise interventions, if you're underweight or your nutritional status is low, you're not going to get the best out of that intervention. So it's important to have good nutrition alongside of that exercise intervention. So this study showed that 20 grams of a whey-based supplement, twice a day, a supplement drink, with leucine and vitamin D, alongside the intensive rehab program, improved their lower leg function and preserved muscle mass in patients with Parkinson's and patients with Parkinsonism as well. And also there's research out of Luxembourg that actually shows that there's a differing effect of the amino acids in different foods. So some amino acids compete with levodopa across the brain, some don't compete, and others actually help levodopa to cross the brain. So we need to know more about the individual foods that actually help to improve absorption of your levodopa. And this is a very busy slide, but again, it's a nutritional researcher who has looked at this and looked at all the different amino acids and which ones are potentially beneficial to improving levodopa uptake into the brain and which ones are competitive. And basically, she states that research in the following areas is strongly supported to determine the safety of regular consumption of targeted amino acids supplementation for people with Parkinson's, and to validate a nutritional supplement drink specifically for people with Parkinson's to help our most used medication to work the best it can. The other thing then is, the flip side of people who are underweight, there are obviously people who gain weight. And there are people who are on things like agonists, like Requip, pramipexole, and they basically have a they increase their dopamine excessively and causes a sort of compulsive tendency in terms of their eating. Overeating can also happen when you have these fluctuations. So basically what they call is a hypodopamine episode. So basically when you're going off, your body is looking for. So it's a bit like when you're insulin, again, if you're diabetic and your blood sugars drop, people start looking for sugary foods to boost that up. It's a bit the same in Parkinson's. When the dopamine drops, the body is trying to is craving sugar because sugar basically boosts your dopamine. So the body is very cleverly trying to, counteract that. So basically, in terms of also if you're, I think that's probably my time up, in terms of your DBS, if you're going for DBS, you really should have a consultation with a dietitian, because we know that people up to a year after DBS can gain up to 6 kilograms of extra weight. So we need to avoid that happening. And the other thing is a lot of people with Parkinson's ask, what's the best diet for Parkinson's? So there's a whole range of different things. But the best one at the moment is the Mediterranean diet that's showing the most signals. And there's been some randomized controlled trials, small ones, to show that it potentially can slow progression and definitely helps Parkinson's symptoms. But the reality is that the best diet is the one that is personalized to you based on your age, your sex, your lifestyle, what goals you have, your culture, your lifestyle, and medical conditions, other medical conditions that you might have. And also we need to culturally adapt the Mediterranean diet because it's not appropriate for everybody, but the principles are what counts. But there are adaptations of the Mediterranean diet for the African heritage and for Asian diets as well. And the personalization of your diet can be done with the guidance of a dietitian who looks at all of these elements of your diet to help you live better with Parkinson's. But currently, 85% of people with Parkinson's don't have access to a dietitian. So I just want to ask here very quickly, how many of you here can put up your hands and tell me that you've seen a dietitian? So I think that's none. So that's not surprising. But you can request through your neurology team, through your general practitioner, through your community health centre, perhaps. I don't know how it works here in France. And also there's often private dietitians that you can see. But the future of personalised nutrition is bright for Parkinson's because the only way we can go up is up to improve the lives of people with Parkinson's. I feel very passionately that there's obviously, a lot about finding something to slow progression and a cure. But there's a lot that we can do with nutrition to improve your lives today. So I would encourage you to ask to get to see a dietitian to help you with that. And just finally, the France Parkinson's have a fantastic resource that's available, a dietetic booklet, nutrition booklet, and also there will be programs that I'm developing that will be launching soon as well on the My Moves Matter website. I just want to mention that I've actually got a study that my old professor that I did dietetics with in the north of Ireland has actually got a Food for PD program research pilot that's happening in Northern Ireland. So I'm just showing that there are sort of movements towards improving care. And the last thing I want to mention with regard to the women with Parkinson's is we're doing a pilot for women with Parkinson's in France, specifically young onset women, that's been funded by France Parkinson's and will be starting towards the end of this year in 4 neurological centres in France. So please get in touch if you're interested in taking part in that. So thanks very much and sorry for running over.
Thank you, Michelle. You're surely very passionate about what you're saying. We've asked a question about nutrition to the audience. I don't know if you've seen it. We've asked what the best diet would be. So what is the best diet to make your gut bacteria happy? So you have several options. Feed them a pizza, going keto, or it's moving, feeding the Mediterranean diet. So if you listen carefully to what Rochelle just said a few minutes ago, I think the answer should be obvious. So I see the Mediterranean diet is winning the race, which is good, right? Going keto, you wanna comment on going keto rapidly?
It's working. Yeah. So the ketogenic diet, there is a bit of interest in that. There's been a couple of studies, but they've literally been in sort of 8 to 10 people, and it's shown, potential to improve symptoms and maybe some signals of slowing progression. But it's actually a very hard diet to stick to. And actually, there was at the Movement Disorder Congress there recently, there was a paper, an abstract on it, where a group in Canada were actually doing a ketogenic Mediterranean diet sort of intervention. And basically, they show that people couldn't adhere to the ketogenic diet. So I think that's the biggest problem with it. And that's why I mentioned about, the best personalized diet for you is the one that you can stick to long term. And also with the ketogenic diet, often there's quite a lot of weight loss. And actually that weight loss is worse for your Parkinson's progression than taking the keto diet. So that would be the position on it. But I think it is that we need more research, and potentially it might be specific people. So maybe a cohort of patients who are more on the overweight side, younger, might be able to adhere to that diet better.
Thank you very much. So I think, a key message from that we get today is that if you want to stick to something, you have to do something you like, as far as physical activity, but also as far as the food that you're going to take. So it's very important.